Imagine you're standing beside a nursing student during a patient encounter. They notice something that doesn't quite fit the plan of care, but they hesitate, not because they don't have an idea, but because they're asking themselves, if I speak up and I'm wrong, what will my instructor think of me? My name's Lindsay Powell, and I'm going to chat with you about how that moment isn't simply about confidence, it's about psychological safety. Psychological safety is the belief that learners can ask questions, admit uncertainty, and acknowledge mistakes without fear of humiliation or unfair punishment. Importantly, it doesn't lower expectations or excuse unsafe practice. Instead, it creates the conditions for honest dialogue, timely correction, and meaningful learning. As an adult gerontology primary care nurse practitioner student completing a graduate certificate in nursing education, and as an outpatient wound care nurse, I've become increasingly interested in what faculty can intentionally do to create these learning environments. During my clinical rotations, I occasionally hesitated before asking questions because I didn't want to appear unprepared. Fortunately, my preceptors consistently responded with curiosity instead of criticism. Those experiences reinforce something the literature repeatedly demonstrates. The faculty response often determines whether learners become more willing or less willing to speak up in the future. So, what does the evidence tell us, and how can nurse educators intentionally create psychologically safe learning environments without sacrificing rigor? Let's look at what the current evidence tells us about that. Although researchers have studied psychological safety in different clinical and simulation settings, one message is remarkably consistent. Students learn more effectively when they feel safe enough to reveal their thinking, ask questions, and acknowledge uncertainty. One of the strongest themes across the literature is that psychological safety influences learner engagement. In their qualitative study, Lyman and Menden found that nursing students viewed psychological safety as affecting nearly every aspect of their clinical learning, and that includes participation, confidence, and willingness to engage in patient care. Students described being more likely to ask questions and think through clinical problems out loud when they felt respected and supported. In contrast, when they anticipated criticism or feared embarrassment, many became quieter and or less willing to participate altogether. Another important finding from the literature is that faculty and students don't always define this psychological safety in the same way. So Turner and colleagues found that faculty are often focused on preparation, designing simulation, and teaching strategies, while students emphasized relationships, respectful communication, and the way that feedback was delivered. In other words, thoughtful educational design is absolutely important, but it cannot replace trust between the learners and the educators. The literature also suggests that psychological safety supports the development of clinical reasoning. Learning to think like a nurse or a nurse practitioner requires students to verbalize their reasoning, test out ideas, and occasionally just be wrong. When learners fear negative judgment, they may keep that reasoning to themselves, and that limits opportunities for faculty to identify any misconceptions and provide coaching. As several authors suggest, educators can't strengthen reasoning that they don't ever hear. Reflection and debriefing emerged as another really consistent theme. So, Stephen and colleagues found that emotional safety influenced how nursing students learned from patient safety events, while Dryfurst's work demonstrates that structured debriefing and reflection activities help learners move beyond simply identifying any mistakes they might have made into understanding why they occurred and how to improve their future practice. These findings are closely aligned with experiential learning theory by showing that reflection can transform experience into meaningful learning. Finally, the evidence suggests that psychological safety can intentionally be developed rather than be left to chance. Vaughn and colleagues evaluated the STEPS framework and found that students reported greater confidence, stronger perceptions of support, and an increased willingness to learn from mistakes after participating in the intervention. Although this study relied on student perceptions and did lack a comparison group, it does provide encouraging evidence that these faculty behaviors and structured educational strategies can increase psychological safety. It's also important to recognize the limitations of the evidence. So much of the current research focuses on student perceptions, simulation experiences, or qualitative findings rather than actual direct patient outcomes. So while the literature strongly supports psychological safety as a way to improve engagement, reflection, communication, and clinical reasoning, it does not yet prove that these interventions directly reduce patient care errors. So, recognizing those limitations is important because it does allow us to make evidence-based recommendations without overstating what the research currently does support. Taken together, the literature points toward a clear conclusion. Psychological safety isn't created through one conversation or one teaching strategy. It develops through consistent faculty behaviors. So, setting clear expectations, encouraging curiosity, facilitating meaningful reflection, and providing supportive but honest feedback. Those findings naturally lead me into my 3 recommendations for nursing faculty. Based off this evidence, these 3 recommendations for nurse educators can help foster psychological safety while maintaining high expectations for student performance. My first recommendation is to intentionally establish psychological safety from the very beginning of the clinical experience. Rather than assuming students know it's okay to ask questions, faculty should make those expectations absolutely explicit. Lyman and Menden, Turner and colleagues, and Vaughn and colleagues all emphasize that trust, clear communication, and supportive behaviors from clinical faculty are foundational to psychological safety. One practical strategy is a brief learning contract, and this can be verbal before the first patient encounter. For example, I might say to the student, I expect you to think out loud today. So if you're uncertain, I want to hear your reasoning because that's how I understand how you're thinking. If I interrupt, it's only because patient safety becomes first, not because I think that you're failing. We'll always talk through the reasoning afterwards. I also appreciate the question, what helps you feel most comfortable asking for help? That simple question acknowledges that every learner brings different experiences and different levels of confidence. In my own wound care practice, I could begin the day by asking what assessment skill a student most wants coaching on. Let's say it's vascular, and they do miss an important vascular finding. I'd intervene immediately for patient safety purposes and then debrief privately afterward. Patient safety remains the priority in this scenario while the student's dignity is preserved. Once that foundation of trust is established, my second recommendation is to make reflection and debriefing a routine part of this clinical teaching practice. Kolb's experiential learning theory reminds us that experience becomes learning through reflection. Similarly, Stephen and colleagues found that emotional safety did influence how students learned from patient safety events, while Dreyfus demonstrated that structured debriefing helps learners analyze their clinical reasoning rather than simply focusing on whether they were right or wrong. A strategy I would use is a brief 5-question learning huddle after selected patient encounters. 5 questions would include, what did you notice? What was your working explanation? What went well? Where were you uncertain? And what will you do differently next time? These conversations only take a few minutes, but they encourage students to explain their thinking while giving the faculty the insight into how their reasoning is clinically. Just as importantly, faculty should recognize when psychological safety has been disrupted. If I responded too abruptly during a busy clinic day, I could repair that interaction by saying something like, I know I interrupted you quickly. Unfortunately, patient safety required it, but I'd still love to hear what you were thinking. That simple conversation reinforces both accountability and trust. And my third recommendation is to deliver feedback as coaching rather than judgment. So Johnson and colleagues describe psychologically safe feedback as honest, specific, and collaborative. Turner and colleagues also found that students often remember how the feedback was delivered just as much as the feedback itself. So rather than saying, you missed the edema upon assessment, I would ask, walk me through your reasoning and your assessment. What were you noticing and what diagnoses were you considering? How might the edema change your differential? That approach helps students strengthen a reasoning process they can apply to future patients rather than simply correcting one mistake. Finally, it's important to evaluate whether these strategies are working. Faculty can use student evaluations, reflective journals, direct observation of participation, clinical reasoning rubrics, and brief psychological safety surveys to determine whether learners are becoming more comfortable asking questions, thinking aloud, and seeking feedback. Together, these recommendations create a progression. First, we establish trust. Next, we help students reflect on their experiences. And finally, we provide coaching that strengthens clinical reasoning. Each recommendation is grounded in the current literature and provides practical strategies that educators can immediately incorporate into their clinical teaching. As I reflected on this topic, I realized that psychological safety isn't simply another teaching strategy I'll use in the future. It's become a foundational part of how I think effective clinical education should occur. My philosophy on teaching is grounded in cura personalis, or care for the whole person. For me, that means recognizing that students bring previous experiences, different levels of confidence, and understandable fears into every clinical setting. Caring for the whole learner doesn't mean lowering expectations. Instead, it means creating an environment where students feel safe enough to ask questions, expose their thinking, and learn from mistakes while still being held to that high standard. This philosophy also aligns closely with Kolb's experiential learning theory, which reminds us that experience alone does not create learning. Students must reflect on their experiences, analyze their decisions, and intentionally apply those lessons to future patients. That's why structured reflection and coaching are such important parts of my recommendations. They help transform experience into clinical reasoning. Throughout my own clinical rotations, the learning moments I remember most weren't when a preceptor simply gave me the correct answer. They were the conversations that followed when I was asked to explain my reasoning, challenged to think differently, and encouraged to connect my assessment findings to my clinical decisions. Those discussions didn't just improve my knowledge, they changed how I approached the next patient and how I think. Because of those experiences, I see my future role as a nurse educator less as someone who delivers information and more as a facilitator. My goal is to develop learners who can think independently, communicate openly, and recognize when they need help. I also believe autonomy should grow alongside competence. As students demonstrate stronger clinical reasoning, faculty should gradually step back while remaining available to support safe decision making. Ultimately, the current evidence and my own experiences lead me to the same conclusion. Psychological safety does not replace rigor, it makes rigorous learning possible. When students feel safe enough to expose their thinking, educators can identify any misconceptions, provide meaningful feedback, and strengthen clinical reasoning before those habits become clinical practice. As I prepare to graduate as an AGP-CNP and continue to develop as a nurse educator, that's the kind of learning environment I hope to create. I'd like to leave you with one final thought. The next time you begin a clinical day with a student, Tell them exactly how you want them to bring you uncertainty. Then let your first response prove that you meant that, because psychological safety isn't about protecting students from failure. It's about creating the conditions that allow them to be the safe, thoughtful, and reflective clinicians our patients deserve. Thank you.